Ladies and gentlemen, thank you for standing by and welcome to the COVID-19 media briefing. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session, and instructions will follow at that time. If anyone should require assistance during the conference, please press star then 0 on your touchtone telephone. As a reminder, this conference is being recorded. I would now like to turn the conference over to your host, Mr. Mike Schumer. Please go ahead, sir.
Thank you, operator, and thank you to everyone for joining us for today's COVID-19 media call for June 10th. Governor Walz is not on today's call. We'll start with the situation report from Commissioner Malcolm, and following that, we'll get an update from Infectious Disease Division Director Kris Ehresmann. After those updates, we'll open it up for questions from reporters on the line. And now we'll turn it over to Commissioner Jan Malcolm.
Thank you, Mike. Good afternoon, everyone. I will begin, as usual, with the global and national update. As of early this morning, there were above 7.2 million confirmed cases of COVID-19 around the globe and 411,000 deaths. In the United States, as of this morning, we were just under 2 million cases and 112,000 deaths. Here in Minnesota, we are at a new total of just under 29,000 laboratory confirmed cases, 28,869. This is an increase of 352 laboratory cases from yesterday. That is on a testing volume of 8,866 tests processed yesterday. That is our highest number for a Tuesday that we've ever recorded. You may recall that Tuesday tends to be one of the lower days of the week for reporting, as that reflects largely collections from Sunday, and we know that that tends to be a lower day for the most part. While this increase of 352 cases is the first increase we've seen in a few days, it does kind of continue that pattern that we've talked about before of a number of days of decline, several times now, followed by an uptick for a day or two, back up into higher case numbers. So that is continuing here. While this increase in case counts also means a bump up in the case positivity rate just for the current day's numbers, it's good to note that both of these figures, the case counts and the case positivity rates, are both below where we were at the end of May. We will be watching closely, obviously, to see what happens to these numbers in the coming days, to the extent that that may reflect impact of prior reopening decisions and, of course, the tragic events and the mass gatherings of the last couple of weeks. We also had an additional 19 COVID-confirmed deaths reported yesterday, bringing us up to a total of 1,236. Of the 19 reported deaths yesterday, 7 of these were from Hennepin County, 3 from Ramsey, 2 each in Anoka and Crow Wing, 1 each in Clay, Dakota, Itasca, Nobles, and Scott counties. This includes 4 persons in their 90s, 7 in their 80s, 5 in their 70s, 2 in their 60s, and 1 person in their 30s with a history of prior underlying health conditions. 13 of these deaths occurred in residents of congregate care facilities. Something I think good to note is, as we've tracked the number of additional long-term care and congregate care facilities reporting cases each day, we've seen a steady and really pretty impressive decline over the last few weeks in the numbers of new facilities reporting cases. On a running average 5 weeks ago, the average was over 23, about 23 new facilities reporting cases each day. This week, that's down to 5 new facilities per day. And again, this is the inclusive definition of congregate care facilities, including adult day, group homes, mental health and substance abuse treatments, and the like, in addition to nursing homes and assisted living. So just a point of context there. The hospitalization statistics continue to be stable or showing an improvement. We are reporting 28 fewer people in the hospital as of yesterday. and that reflects 6 fewer ICU patients and 22 other acute care patients fewer than the day prior. Excuse me. I'd like to just make note of the fact that today is the beginning of the phase 3 of the Stay Safe Minnesota plan that Governor Walz announced last week, including a gradual reopening of further economic sectors and further social gatherings to allow a cautious and safe reopening of things like indoor dining, fitness centers, and entertainment venues beginning today. Customers and employees will be either strongly recommended or even required to wear masks in these settings, and will be required to adhere to appropriate social distancing measures to continue to work to prevent the spread of COVID-19, which is very much still with us. The governor has repeatedly thanked Minnesotans for the very real sacrifices that have been made to slow the spread of COVID-19 by taking these strong community mitigation actions. We know the impact that has had on our businesses and on our lives in so many dimensions. And we're grateful for Minnesotans being all a part of this effort to help us respond and manage this pandemic in our midst. And while the pandemic most certainly does continue, the work done in these recent weeks has left us in a better position to be able to turn the dial toward further reopenings, which we know is important not only for our economy, but also for our social, emotional, and mental well-being. Since the start of Minnesota's COVID-19 peacetime emergency, the state has prepared for gradual reopening by working closely with the healthcare sector to help expand healthcare capacity, intensive care capacity, and procurement of important equipment such as additional ventilators and personal protective equipment. For this reopening to work, and for Minnesota and for all of us to continue moving in the direction we all want to go, it's very important that each of us do our individual part to help limit the spread. We need to increasingly rely on each other's good decisions to keep our state and our most vulnerable neighbors safe. We must continue to wear masks, to wash hands, to stay 6 feet apart, to work from home when possible. Those practices have been the underpinning of all of the efforts that have helped us to slow the growth of the epidemic, to buy us time to learn about and prepare to manage this virus. And these same practices are what will help keep us safe during this next phase of our response, where we will be having more interactions, all the more important that those interactions be done in the context of safe personal practices. As I've said several times before, though we don't know for sure what shape the pandemic will take in the days and weeks to come, whether we will stay on what we've described as somewhat of a plateau with small up and down waves within it, whether we will see a more rapid growth in new cases and a resumption of that climb up the steeper part of the curve, as we've talked about, or whether we'll see a reduction in cases in the coming weeks. We don't know what the future shape of the curve is going to be. This disease is continuing to prove highly unpredictable in the way it is evolving in different countries and different communities. So we really need to find a way to live with this, to assume that we will face the likelihood of many more months of the disease being very present in our communities with very low levels of population immunity and with, unfortunately, still no effective treatments or preventive measures like vaccines. So what we're doing is accepting a certain level of risk to move forward in all these other important measures, other health concerns, economic concerns, mental well-being, quality of life concerns, moving back toward more of the things that we value so much and critically need, like our economic security. So taking a certain level of risk while taking steps to prevent that risk from growing out of control, to prevent a wave of cases jeopardizing the health of our communities and our neighbors, and a wave of cases overwhelming our healthcare sector. So our goal all along, and certainly in this next critical phase, is to find a proper balance of protections in a way that promotes the best interests of our state. I'd like to speak a little bit about community testing following the large gatherings that we've seen in protest and community response to the tragic events of the last couple of weeks. As you know, we announced 4 community testing sites in Minneapolis and St. Paul that ran yesterday and again today. We know how easily COVID-19 can spread, especially in large groups of people who are close together for long periods of time, engaging in the kind of activities that are very characteristic of protests: chanting, singing, loud speaking, etc. These gatherings, the protests, the vigils, the neighborhood events, all of these represent environments where the risk of spread is increased. And we've asked people who've participated in these types of events 5 days ago or more than 5 days ago to please seek out testing, even if they do not have symptoms. These community sites are specifically designed to serve people who live in the neighborhoods most heavily impacted by the recent events of the last 2 weeks. The testing events went quite smoothly yesterday. More than 1,100 tests were done across the 4 sites, and they're back out there today with, I believe, even more people being tested. I want to really thank all of the employees from our agency, the Minnesota Department of Health, as well as our partner agencies and so many local partners for setting up these testing sites in really very short order. They did some amazing work over the recent last few days to get things ready, and the response of the community to date shows how important that work is. I do want to emphasize that it's important that people sign up for an appointment time ahead of showing up at these community sites. That sign up is on the MDH website, and that's just very, very important to make the testing process go smoothly and to make sure that we capture the information so that we can get test results back to people. The sites have extremely limited capacity for walk-in appointments. So again, it's helpful for people to have an appointment so they know that they're going to be able to be tested. And if people come, there is some, but very limited, as I said, capacity for walk-ins. People should be prepared that if they don't have an appointment, they might be asked to come back later or come another day or be referred to another testing location that can accommodate them. We do know that the appointment slots are all full for the rest of today with limited walk-in, walk-ups available. We are going to be opening up registration for additional dates very soon. So stay tuned for more details on upcoming events, as well as the results of these tests as our labs process them in the next coming days. Our goal is to get results back to people within 72 hours. People who test negative will receive an email or a text, while people who test positive will receive a phone call. So again, thank you to Minnesotans, thank you to our community members for seeking out this testing. It's important for your own health, as well as for giving you information that can help us prevent the further spread of this disease. With that, I'd like to turn it over to Kris Ehresmann.
Thank you, Commissioner. I just have a couple of brief points to make, and that is to clarify some things that were related to a health alert that we sent out. The agency sends out health alerts to make providers aware of important messages that they need to know about, and we did send out a health alert a number of days ago related to updating our testing guidance. And one of the elements of that has caused some confusion, so I just want to clarify. We want to clarify for healthcare providers that the recent guidance we issued related to testing of asymptomatic individuals who are in a congregate care setting does include those in group homes. Certainly, there's been a lot of discussion about congregate care, long-term care, and while we have intended to help to differentiate what that means as we've tried to be more comparable with our rates to other states, But in general, when we've referred to congregate care or long-term care, we include, as you heard the commissioner say, a broad range of different types of services, including group homes. And so we want to be clear that when we're talking about testing of asymptomatic individuals in congregate care, we do mean group homes. So if you're a provider and you have someone who either works in a group home or you have a group home reach out who would like to get residents tested, that would be a group that is very much appropriate for testing based on our guidance. And we, in addition to that, as you've heard the commissioner say, we did send out a message last week clarifying that we want providers to provide testing for asymptomatic people who ask to be tested, having been part of protests or other recent large group gatherings. So just to clarify that when we're talking about testing for asymptomatic people in congregate care, that absolutely does include group homes, and we want to make sure that the individuals as residents or as staff for those facilities have the ability to be tested. And that's all I have, so I'll turn it back to you, Mike.
Thank you, Kris. We will open up for questions now, and as we do, we'll ask that reporters limit those questions to one primary and one follow-up so we can get to as many as possible. With that, operator, we are ready to take questions.
Thank you, presenters. Just a reminder, if you would like to ask a question, you'll need to press *1 on your telephone keypad. That's *1 to ask a question. We have your first question from Jeremy Olson from Star Tribune. Your line's open.
Yes, thanks. Commissioner, you've talked often about the internal measures you're looking at, but occasionally you'll mention looking at what's going on elsewhere, other countries, other states. And I'm wondering, A, what other areas you look at for reference, what countries or states you're looking at to see what Minnesota can learn from, and specifically also about the latest status in Wisconsin. The numbers there, I mean, it's a comparable state, but it has so many fewer deaths there, and I wonder if you've taken any hard look at what's been different there that could explain that variation.
Thanks, Jeremy. Yeah, and I'll certainly invite Kris to comment too on particular states that she and her team are looking at. But certainly the states that had the earlier experience have been instructive. Washington State was and remains one that we look to for lessons about phases of the epidemic and what they learned and how they prepared and responded. But then certainly our regional neighbors are of interest too. Wisconsin, very definitely. Indiana, Ohio, Illinois, and we've talked just this morning, in fact, about getting a call with some of our immediate neighbors. We do talk frequently among state health officers. I know Kris talks with colleagues around the country to generally prepare notes, but we are specifically interested in talking in more depth with Wisconsin about their experience. So we very much look at our neighbors, look at the region, and look at states where they may be experiencing sudden changes in their patterns. There's been some attention just lately to Arizona and Utah, for example, and what might be learned from kind of the sudden rise that we're seeing in those states. Kris, would you want to add anything?
Sure, Jeremy. Yes, we have been looking at Wisconsin and trying to do some comparisons, and they have a slightly larger population, virtually the same number of tests that have been done, but as you've indicated, fewer cases. And we have talked with their EPIs and haven't heard that they're doing anything necessarily different. We have noted a couple things. One is that they do have fewer long-term care outbreaks than us. Their definition is different. They're focusing on assisted living and skilled nursing, but even so, they have fewer outbreaks there, and we're not seeing the same level of outbreaks in food processing or manufacturing plants. But there hasn't been any sort of definitive red flag that, they're doing something particularly different from us that has made a difference. And then in terms of Arizona and Utah, both of those states have, removed their stay-at-home orders, and so they're attributing it to the fact that restrictions have loosened up in Utah over a month ago, in Arizona on May 15th. So Wisconsin's restrictions ended, I think, on May 14th. So, we may start to see some changes there, but that's what I have on those two things.
Thank you. And as an unrelated follow-up, I wanted to clarify this. Some people who participated in protests could actually be 14 days out from exposure time, and in theory, that's past the incubation period. If someone has been in a protest 14 days ago only, do you want them to come in for testing too, or is there an expiration date to when they should be coming in for that?
We're still asking them to come in for testing, even if they're right on that cusp of the 14 days. So, yep, we are still asking. We are still suggesting that they consider being tested.
We have your next question from Emily Havoc from Care 11. Your line's open.
Hi, Kris and Jan. Thank you. I'm looking here at the dashboard on the response capacity, and I just have a question about the ICU capacity. We're seeing, as you've said, stable or even lowering hospitalization and ICU numbers. So it says we have 193 people in the ICU today, but we have 1,075 ICU beds in use. Obviously, there are people using ICU beds who do not have COVID-19. I'm just trying to clarify, are all those other ICU beds in use for other things? And that does put us fairly close to our capacity here at just over 1,200. So are you concerned about that at all? What is the ICU bed situation across the state? And then are there specific hospitals that are really maxed out while others in other areas are just fine? Just looking for a little more detail.
Yes, and we can certainly get Dr. Hick and Marie Dotzeff to join us again for one of these calls in coming days, just to drill a little deeper into this picture. But basically, yes, the COVID-related hospitalizations, both general acute care and ICU, have been coming down over the last number of weeks, generally stable or even at lower levels than we've seen in some time. So the rest of the hospital use is driven by a return to more normal, in quotes, operations in the hospital. So as you recall, elective procedures, which meant non-emergency kinds of procedures, not necessarily even elective really, but a lot of important care was deferred during that period, and that's been opened up. And we're really glad to see the more normal use rates reemerging, and very important care being caught up on in terms of cancer surgeries and cardiovascular procedures and the like. So we think that the hospitals returning to a more normal level of operation is a good sign, as long as, again, we are prepared to pivot when necessary to create the added space for potential resurgence in growth in COVID care. So we are. It's not unusual. The hospital sector has gotten quite a bit more lean over the last decade or more. We have fewer hospital beds than we used to, and running at a pretty high capacity is now the norm, which does create challenges for preparing for emergencies and surges like this. But I think it was a good question, and I think both trends are true. The COVID cases are stabilizing or trending down, and other hospital use is trending up.
Just to follow up, does that ICU overall capacity right now and the number of beds in use, is that a concern to you guys right now? I know you're watching it, but as of now, you're not worried about it?
That I think being very watchful is the right word. And thanks. I realize I didn't answer one part of your question, which is there some concentration of capacity constraints in some hospitals, and that, as we've talked about before, that is the case, that some are fuller than others, particularly the level 1 trauma centers. One would expect to have more capacity in use at any given time for critical care, especially. And so that does continue to be the case, and our system and our plans in place rely on real-time exchange of data among the health systems and assistance where they need it in helping to move patients around to where there is capacity. So that system has been stood up and is functioning.
We have your next question from Catherine Richard from Minnesota. Your line's open.
Hi, this is Catherine with Minnesota Public Radio. So looking at other states this morning who have started that reopening process but are now seeing, more and more people in the hospital, Texas, for instance, I mean, what is that telling you, and how are you looking at those states where they're starting to see spikes after reopening in terms of how it's informing your plans in the next few weeks as we start to reopen and deal with, potential cases coming from the protests?
Well, definitely, we look to those for whatever lessons can be gleaned, and as I think Kris mentioned, it's pretty notable that our near neighbor, Wisconsin, has not yet seen the increase in cases from significant reopening over there. So, and unfortunately, what we've learned is that we've seen what the shape of the epi curve is in one community doesn't necessarily predict all that well what it's going to be in another community for reasons we don't completely understand what drives the variations. Some of it may be super spreader events where we have unusual spread from a singular event that can just magnify really exponentially fairly quickly. But this is a kind of a cautionary note. We've said all along we need to be watching certain data very carefully. We've got a whole bunch of different indicators that we track on an ongoing basis. We look at not only test rates and positivity and percent of community spread, which we talk about a lot, and we're watching closely to make sure those measures stay stable, but also what data we get from what kinds of symptoms are bringing people in to see the doctor or into the emergency room and that sort of thing. So I think we're kind of a lot of eyes on a lot of different data sources, but watching very carefully. Kris?
I was going to say, the thing that I would add is, we've said, well, we want to wait at least 21 days after an action is taken, because we want to wait for a full incubation period and then allow for some, additional time to see what is happening. And for sure, we're past 21 days on our, May 18th kind of opening up again. But there still needs to be time to be able to evaluate the opening that was June 1st, and obviously there's greater opening that will be happening today. So we're going to continue to monitor that, and we want to make sure that we're allowing for enough time before we, make a pronouncement. But I do think, as the commissioner said, we feel encouraged that with the changes that were made as of May 18th, we have not seen, a dramatic increase in cases. And it can have to do with the geography, different populations, but at least we know that we're plenty of time out from that, and so that's positive, and we're going to continue to keep monitoring what's happening in the next days, given all the events, the mass gatherings, the additional opening up, and we'll continue to monitor the impact that's having on our cases.
Just a quick follow-up. You mentioned the community testing sites around the protest areas. Are you tracking people who've gotten tested who are at the protests who aren't going to those sites, like people who might have just used their provider's testing site. Are you getting that information, and are you seeing any patterns in that information so far?
Yes, this is Kris. That's information that we do collect. We do ask about mass gatherings, and we're being somewhat specific, so we will have that. But again, it takes a while between the time someone's tested, we get the results, and we speak to them. But we will have that information.
Okay, thank you.
We have your next question from Kris Megan from Pioneer Press. Your line's open.
Hi, thanks. Yeah, I was wondering if you could give us an update on serologic testing. I've been off for a little while, but I haven't heard too much new information about that and whether or not it's available to folks or being used. I think the last update we had was over a week ago with some discussion about how the state would be using antibody testing. I'm just wondering if you could provide any type of update on whether or not that's being used more prevalently now.
Sure. Kris, can I ask you to take that?
Sure. We are continuing to get results reported to us so that providers that are doing antibody testing do report those results. We haven't been including that on the web at this point because, as we've talked about in the past, much of the serologic testing that is available is being done and has not been FDA by tests that are not FDA approved, so we're still sort of struggling with how to interpret the data. We do have plans and some protocols to do some population-based serologic surveys to get an idea of what portion of the population may have had infection in the past. And our understanding is that there will be some additional serologic testing that will be coming online. But at this point, we have continued to focus on the molecular testing that indicates whether someone has a current infection.
Just to follow up on that, back when the Mayo Clinic, University of Minnesota Health System partnership was announced, serologic testing was going to be a big part of that. Where does that stand now? Those tests, I believe you had said, were anticipated to be pretty reliable. Are those tests available to people, or is it really still the sort of the Wild West of all these different tests that don't have approval?
Again, Kris Ehresmann, the Mayo and the university serologic tests are reliable tests. So to be clear, they are FDA approved, and they are available. But I don't know that they're available at this point for widespread testing. And one of the challenges I think you've heard us say related to serologic testing is there are two kind of important elements that we don't have, and that is what level of serologic or what level of antibody, indicates protection, and what is the duration of that protection. The current tests are kind of a yes/no. Does someone have antibody or do they not have antibody? And what will be very helpful is when there are antibody tests that are available that will provide a greater level of quantification of the level of antibody and how well that does at, fighting off the virus, so neutralizing the virus. So that's the next level of serologic testing that will be really important. But yes, the yes/no will be useful, and it will be useful for population studies, but it's less useful at the individual level because we can't say if the fact that you have antibodies means that you will have protection, and if you have protection, how long that will last. So those are still some of the challenges, but there is progress that's being made to get more serologic tests available that will help address those questions of the level of antibody.
And any time frame on when that would... Go ahead. Sorry.
Oh, sorry, Kris. I was just going to chime in and just say you're quite correct that as a part of the partnership agreement with the University and Mayo, what we will benefit from is the fact that both of them are really kind of on the leading edge of research on the very things that Kris Ehresmann was just talking about. And they have been doing some serologic testing in that context to try to get more insight into what conclusions can be drawn from serologic testing, and to help inform under what conditions and what timing and so forth those tests are most useful. So they are doing some of that testing. They do not have reportable results yet, but that is something that we look forward to being able to brief you on soon. I know you were about to ask the question about, is there a timeline for when serologic testing will be more, a more clearly articulated part of the state's strategy, and we're actually, kind of working on that now. I've asked that same question for what should we be anticipating in terms of some of the timelines. So hopefully I'll have more to share with you in the next week or so on that question.
Thank you.
We have your next question from Jeremy Olson from Star Tribune. Your line's open.
Oh, I didn't expect to get in there. Just, I guess, a follow-up question regarding the fact that if we've peaked, I mean, one of the things about an effective response is if it works, it'll look like maybe you overreacted. But I still want to ask if there's any look at what's been done so far, and wondering whether we did more than necessary. I mean, there are hundreds of surge beds that may never get used. It looks like we have auxiliary hospital facilities that may never get touched either. I mean, is it too soon to say did we go too far and do too much in our preparation?
Well, you're quite right. That is sort of a frequent question that we get in public health. When prevention works, folks tend to not appreciate the value of having done it, because you never can know what would have happened if you hadn't successfully intervened and done smart preventive action. So I do think I think it's definitely too early to say, have we peaked, and therefore did we overshoot, our preparation? Did we over prepare? We don't know that we've peaked. It's highly possible that we could see the pattern shift again, and the cases continue to grow, and we've also mentioned that even if we are at a sustained plateau for a while, or if we start to see cases come down, if we did in fact hit some sort of a peak and are heading down, that doesn't mean we won't see another a resurgence in the fall and winter. In fact, that's a very possible scenario that we also have to be prepared for. So I would say, even if we end up not using those surge beds, we have already used some. Back to the point that some hospitals have been running quite full and have gone into their surge planning. Even if we don't use them to a great extent, we may very well be needing to use them for a larger peak in the fall and winter months. So I don't think there's any question but that the preparation has been important and useful, and when and how we end up deploying it is yet to be seen. But that we will be far better prepared for what comes next as a result of this.
And this is Kris. I just want to add on to that I absolutely agree that it's too soon to make that determination, and want to acknowledge too that if we see a resurgence, as we've talked about, we don't know if we're in a wave pattern, if we're going to see a drop off for summer and then a resurgence in the fall. But when we next see an increase in cases, our decision making can be informed by what we've learned from this first 3 months or 4 months of response. But additionally, I think we need to keep in mind that we have been responding to COVID really post-influenza. So we didn't have a concurrent influenza outbreak happening while we had COVID. We had our first case in March, which, we can still see influenza cases, and then we moved quickly to a stay-at-home order, which basically eliminated our influenza activity. But coming into the fall, we're going to really be pushing for influenza vaccination. We're really going to be monitoring, but we'll have concurrent, likely, COVID and influenza, which will put a greater demand on our surge capacity for healthcare. So I think that's another thing to keep in mind as we're assessing where we're at, is that this has really been a focus on our ability to surge for COVID. We haven't had concurrent other activity.
Gotcha. And a related question to that is, and I get this a lot from emailers, what happens if we don't have a surge in cases, or severe cases especially, related to protest activities? If that results in no cases, will that allow you to be kind of more bullish on outdoor activities? Will that say something about the safety of being outdoors, even in close quarters?
It's a really interesting question. I'd certainly invite Kris's take on that from a sort of a common sense perspective. That might be a reasonable theory that we had a significant experiment, if you will, with that very question, and if it does not materialize in a large number of cases, one could understand why folks might draw that conclusion. But I would definitely be looking to the advice of our epidemiological and clinical leaders to give a more evidence-based answer to that question. So, Kris, anything you'd want to add at this point?
Yeah, I think we'd be delighted if that was the outcome, and the data from that, and the data that we look at collectively, so not just in Minnesota, but the data that's available nationally about what's being seen post the multiple events that occurred, will really help inform how we go forward. So I think, one thing to keep in mind is that, this feels like an eternity, but it's been a relatively short amount of time that we've been able to collect data on COVID. And we've continued to evolve in terms of our understanding of the virus, how it works, what impact it has on the population. And so the data from these events, both in Minnesota and, as I said, at the broader level, that will all help inform our understanding of how this virus acts and how it affects our populations. And so, yes, if we see that there aren't multiple cases, and that's true in multiple places across the country, we'll be looking at that to see if that will help inform future decisions. So I think even as we're at this point where things seem better and we're looking quickly in hindsight, so it feels like we're turning around really fast to say, well, did we do the right thing? I think people need to keep in mind that we have learned many things from the response thus far, and that will all help us as we make decisions going forward, because as the commissioner said, we're not done with COVID yet. And so, all of the learning will help inform our future response.
Operator, we have time for one more question.
We have your next question from Paul Scott from Forum. Your line's open.
Hi, I wanted to ask again about the serological survey. You said you have plans and protocols. I'm just wondering what's taking so long. It seems like that would be one of the very first things you'd want to find out, right? Do a survey and tell people 5% of the population has been infected or 20%. I'm just wondering what the timeline is.
This is Kris Malcolm. Go ahead. I'll start, Kris, and then turn it to you. So as I mentioned, we are awaiting some information from the testing that the U and Mayo have been doing to help inform us about that. We do have some study designs that have been being worked on that need funding. So we go to the legislature and need to get support from the COVID-19 funds that require legislative approval for that. But we are definitely working on that. Kris?
That was just what I was going to say. So okay. No further comment.
Well, so once you started, how long would it take to deliver a report that said we did this survey and we found that 8% of Minnesotans have been infected with COVID-19?
Well, part of it will be making sure that we have a representative sample, and I know that one of the areas that we're looking at, because of the availability of blood available, is blood donors. We know that there are limitations to how representative blood donors are of the population, but we need to make sure that the sample that we're testing will be representative, because if you're not testing broadly enough, you can't speak for what's happening at a more global level, at the state level. So, but it shouldn't take years, but likely months. So.
Okay, thanks very much.
All right, thank you to all our speakers and the reporters on the line today. If you had a question you were not able to get addressed during the call, please feel free to reach out to our office. Have a good day, and we will talk again soon.
Ladies and gentlemen, this concludes today's conference call. Thank you for your participation. You may now disconnect. 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 May now disconnect.